So thank you everyone for joining us today. My name is Pat Heinrich and I'm the Executive Project Director here at NICHQ. We've come together for our third webinar in a series on health equity, and we've chosen to focus this third webinar on addressing racism and racial bias because, like many of you on the phone today, we know there's an urgent need to address racism as a public health and healthcare crisis. Next slide. We really appreciate you joining us and continuing this conversation today. We have two wonderful speakers with us, my colleague, Dr. Stacy Scott, and Avery DeRosiers from the Global Infant Safe Sleep Center. And they're going to introduce themselves more fully in a few minutes, but I wanted to really thank them both for joining us and sharing their expertise and their unique experiences. Next slide. So today we are going to, over the next hour, focus on the following objectives. We will understand and contextualize the three levels of racism: internalized, interpersonal, and institutionalized and structural racism. We're going to apply a racial equity lens to collective impact-based health improvement initiatives. We'll do that using 6 guiding questions, which we will share with you. And we'll identify key strategies for designing intentional, action-oriented, and strength-based approaches to start and sustain an equity-focused organizational culture shift. Next slide. So before we launch right into this, I wanted to just introduce those of you that are not familiar with NICHQ and tell you just a little bit about the organization that's sponsoring this webinar. NICHQ's commitment to focusing on racial equity and to supporting you in this important work is why we're all here together. For over 20 years, we focused solely on driving dramatic changes in the complex issues facing children's health. Next slide. At the heart of what motivates us is really the belief that children and families deserve better systems and supports so that every child achieves their optimal health. Right now, because of racism, our vision simply is not possible. Too often, children of color in this country cannot achieve their optimal health. We know this is unacceptable, and that's why we're here today. Our goal is to work with all of you to really help change that, to give you some concrete strategies and tools to combat racism in our health systems. Next slide. So with that, I'm going to turn this over to Dr. Scott and Avery to guide us in identifying strategies for combating racism in health systems. Dr. Scott?
Well, thank you, Pat. Next slide. So again, I feel like I want to say that I'm serving in a couple of capacities. Number one and foremost, I serve as the Senior Project Director for NICHQ, and also in the capacity of being a founder of Global Infant Safe Sleep Center. I want to thank NICHQ for the opportunity, for allowing both Avery and myself to share some of the things that we've been working over the last couple of years. Next slide. So I want to thank everyone for joining us today. Again, both Avery and myself appreciate the opportunity to discuss our viewpoint on this important and pressing crisis. From awareness to action, strategies for combating racism in health systems. We choose this strong title because it reflects the lives that are lost each year in this country as a direct result of racism. It shows the urgency of the matter. By combating racism, we are taking action. We are working not only to reduce but prevent something bad and undesirable from happening. We are in the fight of our lives, and we are in the fight to save lives. Our hope is that you do participate. We recognize in many instances talking about racism can bring on a slew of emotions. We ask that you be respectful of others and follow the norms we have listed on the screen. Number one, please ask questions in the chat. Use I statements. Understand intentions are different from impact when sharing ideas in the chat box. and we want you to know that your participation is valued. Next slide. So with that, I want to turn it over to my colleague, Avery. We're going to just give you a little insight about ourselves and why we are here. Avery, are you there?
I am. Thank you so much, Stacy. Can everyone hear me okay?
Yes.
Great. All right. Well, thank you so much. And thank you to everyone who's joining today's call. As Stacy mentioned, my name is Avery DeRogers, and I currently work at the Ounce of Prevention. And I also work closely with Stacy as a consultant with the Global Infant Safe Sleep Center to conduct trainings and workshops similar to the one you're on today. So one thing Stacy and I really like to start off these conversations with is describing our experiences and how that has informed the work that we're doing today. So growing up, I lived in a majority white neighborhood. I attended a majority white school and played on sports teams with girls who, for the most part, looked like me. And as a result, I was nearly 20 years old when I felt the color of my skin for the first time and really began to understand my own racial identity as a white person. So this shift in awareness occurred actually while I was studying abroad in Cape Town, South Africa, where I started to study women's studies and apartheid. And in a homestay with my host family, we began to have a conversation about the residual impact of segregation from the apartheid era on families that were in the community we were with. And this led me to really start thinking deeper about my own neighborhoods back home in the United States and how it wasn't so different. And this realization really did not settle well with me. I immediately kind of shut down and felt really weighted down by the guilt and shame and discomfort and realization that I hadn't ever noticed this before. I started to cry in that conversation. And rather than having an ongoing discussion about structural racism, the focus shifted back to my comfort, and my host auntie tried to calm me down. So I have spent a lot of time reflecting on that day. It really flipped a switch for me that I had been blind in many ways to my own privilege. So I want to say that there has been a lot of unpacking since that conversation. I'm so excited to go through today's webinar with you, really speaking from our experiences, learnings, and working through discomfort and really being vulnerable to have critical conversations. And I hope you come away from today's webinar with some tools to guide your own critical introspection. Next slide.
Thank you, Avery. And for me, I want to take this opportunity to pay homage to my ancestors, both Black and white. Based on family storytelling, I am a descendant of an African enslaved woman that was referred to by the name of Nigerian Mary. Her owner, my grandfather, several generations removed, was identified as a white man of Irish descent who went by the name of Mr. Tom Foley. I was told even after slavery ended, the story goes that she remained on the plantation, which she was held as a possession, as a means to ensure her children would have shelter and food, despite the disparate situation she found herself in. I was born to a single teenage mother in a county hospital in Los Angeles and migrated to Ohio at the age of 14 months. To be raised by a lovely, strong, intelligent Black woman who didn't have the opportunity to be educated beyond the 3rd grade. I was sent away not because my mother was unfit, but because of who she was and the system for which she found herself in. And although I struggled for years with her decision, I thought I was given away. I recognize now the decision she made was the best one, and as I've grown older, I appreciate the magnitude of her sacrifice. I have been impacted directly and indirectly by chronic stress, depression, crack cocaine, addiction, alcoholism, domestic violence, murder, incarceration, poverty, homelessness, financial hardships, just to name a few. I'm a product of systems of racism, paternalism, sexism, segregation, desegregation, affirmative action. I have experienced oppression, marginalization, both explicit and implicit bias, but through it all, I have been able to achieve. I love who I am in this space and time. I am a woman of color, and despite the odds, my unrelenting determination to succeed, allows me the opportunity to spend the next hour with you in my role as Dr. Stacy D. Scott and in our quest to achieve equity for all. Next slide.
Great. And so as Stacy just walked through her lived experience, we've had a lot of conversations with one another over the past few years about really the intersections of privilege and oppression in our own lives. A really foundational article that we recommend everyone read is Unpacking the Invisible Knapsack by Peggy McIntosh. It really outlines very clearly the areas of unearned privilege that I had never examined but really benefited from as a white person. So while there are many areas where I and other white people have greater access to opportunities, resources, and power, the ones that are outlined on this slide are just a sample of what I have found really resonate with me. So starting from the top, having the luxury to really disregard my skin color and use race as my social advantage, having the luxury to ignore or take breaks from thinking about racism. For example, being on this webinar is a really wonderful experience, but if I chose to, I could end the webinar and not think about how racism is impacting me again. I see many examples of people representative of my race in positions of power. This is across my organization, legal institutions, social systems, being able to really easily find mentorship and also have role models in society. I feel at ease in most business, academic, and social institutions where it's easy to find peers who are representative of my racial group. I didn't have to take into account whether or not the school that I went to, the University of Connecticut, would have enough peers of my racial group in it for me to feel comfortable in my classrooms. And I'm given the benefit of a doubt if I make a mistake, so I never feel that I am representing an entire racial group. I'm only representing myself. And so when I reflect on my conversations with Stacy, this is very different now from my first very challenging conversation about racism with my host aunt in South Africa. And I realized that one of those main differences is really having the right language and frameworks to begin to define and understand how my experience moving through society was so much informed by my race. And having the ability to put a name to our lived experience is a really important first step for all of us to begin the self-awareness journey necessary to begin racial equity work. Next slide.
So in response to the white privilege, again, me and Avery have had a lot of discussions and really looked at what did that mean from the lens of being Black and living in America. So we came up and decided that we would take a look at what it took and really look at what Black resilience meant. So for me, I don't have the luxury to disregard my skin color or use my race as an advantage. I don't have the luxury to be able to ignore the concept of race. I see many examples of people representative of my race who are constantly marginalized across institutional, legal, and social systems. I feel isolated in most businesses, academic, and social institution settings, where it's not always easy to find peers representing my racial group. I am not given the benefit of the doubt if I make a mistake. If I have my own personal shortcomings, it really could be attributed to my race. Race is a constant worry, and it's an accepted part of my culture. Next slide. Oh, I believe, hold on just a second.
I am back.
You're back, okay. We had a problem. Okay, are you there?
Dialed it just in time.
Okay.
And so, all right, we're on this side. So wonderful. We are looking about this really intersection of privilege and oppression. And a really wonderful quote that stands out is actually from Audre Lorde, that there's no such thing as a single issue struggle because we do not lead single issue lives. And what we previously mentioned is that having the language to describe our lived experience is incredibly important, but it's also important to acknowledge that there are many aspects to our identities that make us who we are. Individuals don't ever really occupy one part of our identity at a given time, and our entire lived experience is informed by the intersection of all of these identities. So on the screen, we have to the right a few characteristics that vary here. If you don't see a characteristic or identity that is important to you, please chat that into the chat box. We want to absolutely capture those on future slides. But again, when we're thinking about intersectionality, we vary in degrees of those privilege and oppression across our various identities. And understanding our identity and being self-aware of this is a really important first step. So rather than feeling guilty for areas where we occupy privilege, we can begin to reframe our thinking as a call to action to challenge how policies, social norms, and institutions benefit some identities while invalidating others. So to kind of walk us through, I'd love for everyone to take a moment to reflect on this. You can write it down on a piece of paper next to you or come back to it later. But really thinking about whether you're aware of your various identities. For example, what does it mean to be racially white or Black? What does it mean to be cisgendered or gender nonconforming? Are there any limitations in your day-to-day life? And perhaps are there aspects of your identity that are fluid, that have changed over your life, such as your socioeconomic status? How has that impacted you? The next question being, which of your identities are you most aware of in a typical day? These we find are often the points of oppression we have in our life, where we encounter more barriers in a society that's not designed for these types of identities as the status quo. So are there some identities on this list or that we haven't defined here that you're often thinking of as you try to move through your day because you encounter various barriers? And which of your identities do you often feel are not represented or not validated in either your one-to-one interactions with your organization or larger community as a whole? I see some really great chats coming in, so please keep them coming. And finally, something to think about and reflect on, and this is a really critical step for our work in racial equity, is which of your identities are least aware of in a typical day. So think of these from a point of privilege where we can more seamlessly navigate our social structure, which really cater to these identities.
With that, we're going to move on over to the next slide. And so as of that, we're going to talk about the first objective, understanding the contextual 3 levels of racism: internalized, interpersonal, and institutionalized structured racism. Next slide. So with that, I want to go into a little bit of, I'm quite sure all of you all are probably familiar with Dr. Kamara Jones. I think it's important for us to really define racism as a system, and really kind of get a better understanding on what context we are building this webinar on. So according to Dr. Kamara Jones, the definition of racism is a system of structuring opportunity and assigning value based on the social interpretation on how one looks, which is what we call race. She goes on to talk about that as a result of this, we see unfairly disadvantaged some individuals and communities. We also see unfairly advantages of other individuals and communities. We also see that this saps the strength out of the whole society through the waste of human resources. As we move from defining racism and going into institutional racism, also known as structural racism, this particular level does not require a perpetrator. It is the cause of differential access to goods, services, and opportunities of society. Of course, by race. This form of racism is expressed in the practice of social and political institutions, which lead to disparities that exist within systems such as employment, criminal justice, housing, healthcare, education, environmental, and as well political. What we move from there is going into personal mediator racism, according to Dr. Jones. She defines that as prejudice and discrimination. This is where prejudice means that you have the differential assumption about abilities, motives, and intentions of others according to their race. This is where you see explicit and implicit biases come into play. We see the differential actions are based on these types of assumptions, both be it intentional and unintentional. And for some examples, I'd like to list number 1, police brutality, physician disrespect, shoekeeper vigilance, water indifference, and teacher devaluation. I had an opportunity to see Dr. Jones this weekend, and it was great to be able to hear from her perspective around this. We also see that internalized racism is the acceptance by members of the stigmatized races of negative messages about one's ability and its intrinsic worth. We see that this is a form of internalized oppression, which involves both conscious and unconscious acceptance of the racial hierarchy, which whites are constantly being ranked above people of color. Some examples that we see in regards to that is self-evaluation. The white man's ice is colder. That's syndrome. Resignation, helplessness, and hopelessness. Acknowledging racism is not enough anymore as we work toward a more equitable society. Becoming anti-racist, which means playing a more active role in unpacking privilege, relinquishing power, challenging the status quo, and addressing the dynamics that maintain racial inequities in health and our society as a whole are key components in this era of evolution. Okay, let's move to the next slide. So I'm going to go ahead and see has, okay, I'm seeing here that she's asked, can we hear her? No, we cannot. I apologize. So let's get started. Normally we do this together and we hope that she'll join in. So what we want to talk about here really is looking at systems of oppression and their impact. We like to really talk about this together to really look at what are the types and levels of oppression and what the impact they actually have on individuals. So with that, let's get started. Could you push the, go ahead, yeah, push the next piece. Thank you. So what we really talk about and we start out is that we see that racism also shows up like in the public health within our health care and our health equity, but few name the drivers of oppression that uphold the systematic structural racism in terms of the impact that those forces of oppression have on people. When we look at white supremacy, both self-conscious racism of hate, but also the political, economic, and structural systems in which whites are overwhelmingly control power and material resources, we see where white dominance really over Black and brown people is reinforced from institutions and social settings. We have to take a look at rethinking the white supremacy and who counts in the white world.
So primarily, just really thinking about how we need to not only expand our thinking beyond the violence that we might immediately think of when we think of white supremacy with self-conscious hate groups, but really moving into how do we think of white supremacy as the political, economic, and cultural system in which whites overwhelmingly control power. So if we can expand that outrage that we feel towards the more violent, outwardly facing groups to actually be outraged by the same kind of policies and practices that do the same harm.
Okay. And so, and when we start looking at the impact, I thought in an effort to shed light on the systems of oppression, we thought it would be a good idea to also shed the light on the potential impact that these systems may have on the oppressed, focusing on the emotions and feelings one may have. My disclaimer is that I cannot speak for all people of color, but I can share with you my lived experiences and the effects these types of oppressions have on me. So going back to white supremacy, I can say that the impact that I have and the feeling that I have in regards to that is really looking at fear. We just see that the fear and the fact that I'm afraid, to know that it is terrifying that I or a family member could fall prey to an act of violence being precipitated simply by the color of my skin. Lynching, hate crimes, and even police brutality is real for me. Next one.
Great. So testing out, you can still hear me?
Yes, I can.
Great. Okay, so looking at white privilege, we did touch on this a little bit earlier when I shared a little bit of my own experiences, but thinking about really defining white privilege as the ability to move through the world without being stereotyped, feeling or represented or misrepresented in the media. Really importantly, white privilege is that greater access to power, resources, and opportunities that's removed from anyone's individual skill or level of effort. So it is both the privilege of having opportunity and the privilege of being silent when you don't want to enter a conversation because it doesn't feel like it impacts you.
Right. And so for me, when I talk about the impact and how I feel when I think about white privilege, I would say powerlessness, having no recourse, no ability to counteract against a system that is designed to marginalize me. It speaks to the fact that I would never be a true member of the club, no matter the level of my achievement. Next, we move to white solidarity.
Mhm. And so when we think of white solidarity, at first we hear the word solidarity and we might think, oh, that sounds like a good thing. But this is actually solidarity in a different direction. So protecting the comfort of other white people in a situation where there may be interpersonal racism or structural racism playing out. That's actually having an impact on a person of color. So an example of this might be when there's a situation and an insensitive joke or comment is made and it's racially charged, and rather than validating the impact of that comment on people of color in the room, other white people might try to minimize the impact by noting it wasn't the intent of the offender, or it was just a joke, it's not something to get so worked up about. And this type of solidarity and coming to the defense of, or again, keeping silent to prioritize a white person's comfort rather than to acknowledge the impact of the situation and begin to use it as an opportunity to unpack and have more crucial conversations about racism is actually a protective factor for racism. So when we do this, we maintain a sort of fear and hostility as our baseline emotions that we use to inform how we even talk about racism, rather than opening up and being really vulnerable and willing to learn from mistakes that we make and have a greater sense of humility to grapple with racism in our conversations with one another.
And for me, when I think of white solidarity, can't talk now, it makes me feel alone, isolated, disenfranchised. The question I ask myself, well, who stands with me? Next one.
Great.
All right.
And white fragility. So when we start to begin to uncover and really dig into what is whiteness as a racial identity, realizing that you may be a member of that oppressor group can be really confusing and painful. So I gave my example earlier on at the beginning of this webinar about one instance where I didn't react well at all to a conversation about racism, and we spent more time comforting me than we actually spent talking about the topic. So white fragility is the learned stress response, and it's a reaction to dealing with the stress that we feel when talking about racism. It can show up very differently for different people. So similar to how any other stressor would, people might get angry, they might try to over-explain, shut down, cry, or remain silent, again, as examples of these types of reactions to stress. And all of these reactions really serve the purpose of maintaining or restoring a racial equilibrium, or a dynamic that feels, again, more comfortable to the white person in the conversation.
And for me, when I think of white fragility, I say the feeling I have is that of anger, of being annoyed, which stems from not being allowed the luxury to discuss my own racial plight, having my lived experience dismissed because it challenges the perceived notion of what one may refer to as the American way of life. Next.
Great. So now we get to a really important one, I think, especially in public health, white saviorism. And so we think about this as members of the oppressing community seeking out a chance to save those who are of the oppressed community. And usually this is without belonging to, knowing the needs of, or assets of the community that's being served. So while we think of this as being very well-intended, the impact of it can actually cause a lot of harm. This takes on a deficit approach, which assumes one group to have all of the knowledge and expertise, while classifying members of the other group being served as not having the tools, expertise, or abilities to create their own solutions if they were just provided with an equitable opportunity to power and resources.
And for me, when I look at saviorism, I can actually sometimes feel victimized, bamboozled, set up to be knocked down. It perpetuates unhelpful stereotypes. I don't need to be saved. I need justice, fairness, and a genuine respect. Next.
Great. And so then we come to white ally, and we are going to dig deep into this a little bit later in today's webinar, but to kind of start us off with a common understanding and grounding definition. Allies have deliberately and intentionally placed themselves in positions of support rather than in a position of savior, so kind of a counter to what we just defined with white saviorism. And they work to understand the historical and current forms of trauma, their role in perpetuating it, and really provide a voice as needed so they understand the nuances of stepping up and stepping back to support the group most impacted by this form of oppression.
And for me, when I think of white allyism, it makes me feel supported, but cautious, with the concern being that even the best intentions can go awry. Recognizing anti-racist activities can be a difficult role for allies to assume, with the understanding and the responsibility which lies on them, even with or without the input or advice of a person of color. Addressing racism in this case is an ally's burden. Next slide.
Great. So we say all of this to really build the framework of noting that we are not actually colorblind, that none of us come into our experiences completely unaware entirely of race and have that objective sense. So when we leave implicit biases unchecked, it can really feed up to a toxic culture that sustains institutionalized racism and differential treatment for people of color. And this particularly persists in the healthcare settings and in our wider communities. So the normalization of that indifference using colorblind approaches at the societal level, that minimization feeds into microaggressions, which feeds prejudice, stereotyping, and then leads to larger macroaggressions, which can lead to physiological and physical violence against communities of color. So it's really not enough to be not racist or to say, you know, that's not my intent. We need to adapt anti-racist frameworks if we want to have a sustainable shift in how we view Black and Brown lives. Next slide.
Okay, so with that, we're going to move to our objective 2, apply racial equity lens to collective impact based on health improvements initiatives using the 6 guiding questions. Next slide. So how might we confront the status quo of how our healthcare systems are designed? Next slide. So I'm going to give us just a quick kind of run through a little history here, being that is Black History Month, but I think it really sets the stage as we begin to evaluate these savior design systems. In 1928, Lewis Israel Dublin wrote, and I quote, "An improvement in Negro health to the point where it would compare favorably with that of the white race would at one stroke wipe out many disabilities from which the race suffers. It will improve its economic status and stimulate its native abilities as would no other single improvement. These are the social implications of the facts of Negro health." This is a compelling assertion which remains valid to date. The fact that African American populations is the least healthy ethnic group in the United States is not due to chance. The first African Americans were brought to the United States in chains as an enslaved people. The transport itself from Africa to the New World remains one of the best examples of the ability of one sector of humanity working to destroy the health of another. Mistreatment and poor working conditions often left enslaved and prematurely poor enslaved people in prematurely poor health. They were often cast out by their masters, even um, if they were no longer viable and able to work. So in 1832, the first American hospital opened in the United States for the relief and protection of afflicted, aged Africans. In 1947, the first African American earned a medical degree. In 1868, the first medical school established training for African Americans and in 1877, Jim Crow laws were passed that impacted the care for many. So when we think back about this history of the segregated Black hospitals, these facilities were established by whites to serve Blacks exclusively, and they operated predominantly in the South. I would take a chance to say that these hospitals were a clear example of what we have coined the phrase as savior design systems. These type of systems were originally designed to rescue, save, and deliver services to vulnerable communities by members of the oppressing community. These systems did not consider the root causes and institutions that make the population vulnerable in the first place. Systems where policies and practices harm specific racial groups while benefiting or centering others. Systems that are difficult to navigate with or on behalf of a disparate group. Systems that are impacted by segregation and the division often resulting in habits, policies, institutions that are not explicitly designed to discriminate. I hate to say that today, these type of systems still do exist. Next slide. So with that, we see the residual impact of these type of savior design systems. We see that in many cases, individuals' lived experience are less valued than professional opinions when it comes to their care, not taking into the account the impact of racism and other forms of oppression that directs the decision-making process of the person seeking care. And we see that in individuals being criticized and instructed in what to do without taking their lived experience into account. And we see an individual as non-compliant, difficult, or rude, rather than empathizing with the struggle of seeking care in systems not designed for them to succeed. Avery, next slide.
Great. And so then we get to what we think is the next step in the process, being the ally design system. So this moves from the savior design system, which really focuses on a deficit approach, and starts to think about this more through the self-awareness lens. So if we're going down the slide, having the first acknowledging limitations of the overall understanding of disparities group experience, but it doesn't use these experiences as a reason not to act. It might begin to reflect on lived experience, points of privilege and oppression to inform who should be at the table with us. It intends to identify and challenge institutional and systemic racism, and it unites with disparity groups who are being treated unjustly. So recent efforts in public health have really focused largely on kind of, quote, bringing everyone to the table. And this is a conversation that Stacey and I have kind of struggled through for a little while, because this idea of bringing everyone to the table still operates within the confines of white supremacy. Again, we're using white supremacy definition as the larger power dynamics that really maintain the status quo across politics, economics, and institutions. And so we have this mix of really well-intentioned allies that are reaching into communities that are underrepresented to participate in our work. But just bringing people into the project or into the initiative doesn't always mean that there's a shift in the distribution of power and the ability to inform decision-making, or that new voices are represented fairly. And so in an ally design system, there might be that elevated self-awareness and good intention, but the power is still maintained by the ally as the champion of the work. Next slide, please. And so we don't want to minimize at all the importance of allies. Allies are activated and they're working to uncover and work through implicit biases, which is absolutely an important first step. towards advancing equity. However, if we're not careful, and what we hope to kind of warn with is that an ally design system can very easily revert back to a savior design system in which there are inauthentic ways of collaborating or shifting power. So some outcomes that we see of ally design systems are paternalism, using that there's power to have people at the table to begin to take input, but that there's not necessarily the matched accountability of actually then using that input to make decisions. Having one-sided approaches, so really relying on experts despite having people at the table to have the work be done together, so the work is not necessarily reciprocal. And then finally, tokenism, maybe having that perfunctory role or symbolic effort to give the appearance of diversity of inclusion, but not really, again, giving a true voice and power there. So the outcomes of this ally design system really refer to some of these unintended features where allies are still operating within that overarching culture of white supremacy. And without intentionally developing our norms and different ways of operating, these characteristics infuse and inform how allies are going to interact with people. So we need to do better if we're going to collectively advance equity. Next slide.
So as we go into this continuum, our next pieces and our ultimate goal is to work to develop equity and power systems. And these systems are built and governed to center on the experience of disparity groups. We look at accepting racism and other forms of oppression that adversely impact systems of care and place a specific emphasis on addressing the unique needs and the root causes of inequitable outcomes. We look at these systems as a means to be able to deconstruct institutional racism and systematic oppression and reconstruct systems that are rooted in the advanced equity of historically marginalized groups. And of course, we want to be able to share power, ensure diversity, representation, and redistribute resources to establish equitable decision-making designs and implementation processes. Next slide. So with that, what are the residual impacts of this type of system? We will provide trauma and bias reducing care. We will amplify lived experiences. We will be unapologetically name root causes. We will prioritize wellness and of course promote economic equity. Next slide. So, because we're getting so short of time here, we couldn't go into a whole lot of detail, but what we are really looking at, this is our beginning of our conceptual framework of seeing how we move from savior design systems to ally design systems and eventually reaching that equity and power system. We're in the process, again, we're in the early phases of developing this. And what we want to ask from you all is that we need your input. And so after this, we are going to send out a survey and we're going to collect information. And we want to get people's views about, again, how we can make this happen, how we can make this shift. And so we really appreciate your input. And it'll be interesting to hear what kind of systems do you think that you currently are operating in. Next slide. So where do we begin? Next slide. And so with that, I'm going to turn over to Avery because we want to definitely cover the 6 critical questions on what we think we take to help us move into this equity empowered system.
Great. And so as Stacey mentioned, we've really been giving a lot of thought to what exactly will it take to move from that ally design system to an equity empowered system. And we kind of came up with some key questions that can help build out how do we make that shift. So number one, really being unapologetic in naming the root causes of inequities that are at play. So do you use the word racism? Do you use all of the words that describe and define oppression in a way that really validates what's happening at that root cause of the inequity? Question 2 being, what would be different if we centered on the lived experiences? So applying an approach that really focuses on the margins rather than on groups that are more often focused on can actually serve to benefit everyone. Number 3, what would it look like if power and decision-making was distributed equitably? So really matching decision-making power to representation. If we're inviting people to the table, they have a voice and they have the ability to use it. Next slide. Question 4, looking at our data systems. Are we stratifying our data by race, ethnicity? When we do that, how deeply do we continue to follow that route to really get at the causes of the health outcomes we're trying to move the needle on? Question 5, how will the system assess whether the groups are unintentionally impacted? Really taking time, whether we're going through quality improvement work or just designing and at the beginning of our innovation stages, to reflect on how the proposed plans might impact groups with various identities differently. Might it reinforce stigma or even create unintended barriers to care? Again, this is a really important reason why having voices at the table to be able to speak to this lived experience is really important. And then finally, question 6, this kind of gets at the leadership and looking at key ways that community members are actually brought in as advisory board members, leadership roles, and decision-making roles so that they're spearheading the design of our initiatives. Next slide, please.
So as we go to our close and look at objective number 3, we identify key strategies for designing intentional, action-oriented, and strength-based approaches to start and sustain an equity-focused organizational cultural shift. So
Great.
with that, Avery?
Great. And so when we think about a framework that is used a lot in public health, we wanted to use collective impact as kind of an example. So both using that equity empowered framework and those 6 questions that we just ran through, we can kind of quickly run through traditional collective impact here. So just to get a common understanding across the board, the key tenets of collective impact are a common agenda, knowing that all participants have a shared vision for change, having shared measurement, so all collaborating parties really agree on what to measure and are looking for the same outcomes. Mutually reinforcing activities where participants are encouraged to really undertake the specific set of activities that are going to support a coordinated effort for the collaborative. Continuous communication, having a common language and opportunities for regular convening. And then finally, a backbone technical support organization. So usually someone who's functioning as a coordinating center for the work that happens. So if we go to the next slide, we'll begin to see how this might look differently if we apply an equity empowered lens. Next slide.
Okay, we got it. So with that, again, we will keep and definitely look at the common agenda. However, it will be co-created by communities most impacted that mobilizes actions around root causes and systems change, shared measurements with the collection of data disaggregated by race and ethnicity, which measures also look at targeting root causes rather than symptoms of inequity. We, of course, continuous communication through platforms that reach centered populations by champions that are representative of the community, mutual reinforcement activities, which include diverse partnerships, tapping into non-traditional partners from community level organizations, which can guide activities through equity lens to reach a common aim. And of course, a backbone organization with the leadership and voices of representative of the communities in which they serve. Next. So the reality of it all is what? That it is complicated. And employing equity lenses to strengthen collective impact requires a level of transparency that is fueled by bravery as backbones, the balance of courage, humility, empathy, honesty serves as a strong ingredient to be effective and transformative in exploring equity issues. With collective impact approaches, the goal is to strive to be more of an equity empowered system. Next slide. So with that, Avery.
Great. And so we really appreciate all of the wonderful questions that have been coming into the chat. These are both questions that we'd love to continue our conversation today as we're coming to a close of this webinar, but also for you to take back to your own organizations, because we think that they can really begin some very critical discussions that foster, the ability to move forward in this work, to think about what's going to happen next, where are we currently in our systems and institutions, and how do we move forward to that equity empowered system. So we have some questions up on the screen here. Feel free to either start chatting your responses into the chat, but we're also happy to continue offline as well. Next slide.
So with that, Pat?
So thank you so much, and thank you everyone for attending. We have about 7 minutes left, and we have time for a few questions. Let me see. We have a few people who have asked if you would repeat part of the presentation, but since we have offered to share the slides and the recording, I'm going to start with a question from Quinetta Miller, wondering what examples are there of health systems doing equity empowered systems work well? And Sylvia Stratford answered the National Alliance on Mental Health Illness is doing this. I wondered, Stacy or Avery, if you have other examples.
No, I would say, I don't want to say no. I would say that there are organizations that are doing certain things and from a segment perspective really well. I personally have not seen an organization collectively engage in all of the things that we would imagine it would take looking at an equity empowered system. I think we have to take into account when you're making that transition, you're looking not only at just the project and program, but we're looking at administration, we're looking at finance departments, we are looking at all levels of how the system operates and how equity can be infused in all levels of the organization.
And I would just add to that, I think that there are some organizations that have established really clear task forces, and what makes those strong task forces are they have usually a leadership member or level champion on them. They have, again, going back to the actual decision-making power, and that it's really embedded into their strategic planning, so that it's not just kind of a side group that meets occasionally, but that it's built into the strategic plan moving forward the work of the whole organization. And I find when that happens, you begin to see a real cultural shift within the organization itself. It's a great question.
Great, thank you. Early on in the webinar, someone asked, how does one myself handle the situation when a person of color blames me personally for their injustice? I'm not a racist, I just happen to be born white.
That is a great question. And so I think it really comes down to the situation, and I don't know what the context really could be for that. But I think it is important to step back and take a minute to reflect on, was there anything said in the conversation that could have been triggering? If you're open to really digging into that feeling for yourself, maybe taking a step back and reflecting really intentionally on how that conversation went and where there might have been certain points that something might have been said, and not to say, again, let me back up a little bit. When we say we're not racist, sometimes that puts racism in a good, bad binary category, that if I'm being called racist, then that makes me a bad person. And what we really need to shift away from is that feeling of intense guilt of I'm being a bad person, because that puts us on the defensive and unable to really think about, well, what are the structural roots, what are the institutionalized roots making this conversation so hard to have? If this is somebody who's important to you and dear to you, I think it is completely worth opening up a conversation, really from that point of humility and honesty of trying to learn more about where you can go from here.
Thanks, Avery. That's great. And there's some people typing into the chat some more ideas to address that. Another question is, do you think evidence-based practices are also savior-designed systems?
That's a trick question there.
I know.
You're gonna put me out here on here. I think in some cases, yes. To be honest, I would just say point blank yes. Okay. I think again, it depends on when we gather this evidence. Of course, historically, people of color, other oppressed populations are not part of that process of the research and collecting that data. And that's why it's so important that we need to be able to open up the opportunity for people who are, again, impacted by racism and other forms of oppression to be part of this research and research design. I think, again, you know, we talk about being evidence informed, but unfortunately, even in saying that, based on the powers and the systems on which we operate in, evidence informed is not good enough. And so it's a catch-22. I don't know, Avery, you want to add on to that?
No, I completely agree with you, Stacy, and I think having that additional level of sometimes really innovative and important lessons learned are coming from the community and local level. And if that is not valued with the same level of expertise as the person with a PhD at the end of their name or someone who works for a national level organization, then we can't possibly begin to move the needle on health outcomes because we're not listening and aware of what's happening on the ground.
Thank you both. Well, we're just at the top of the hour, and I want to thank everyone so much for participating today and sharing your questions. I do want to let you know that we recognize there were many more questions in the chat that we didn't have a chance to answer. I want to thank others of you who did answer each other's questions and shared wonderful resources. But we do want to be sensitive to time, so we're going to end the webinar. We will be sharing a recording of the slides and the slides, and we'll share the information that was in the chat. That should be available on the website in about a week. And we'd like to remind you again, Stacy mentioned at the beginning, that we have a follow-up survey about the event. We're adding the link into the chat box. If you just click on it, we would really appreciate your feedback. We've gotten some great feedback throughout the call that you found this helpful and that you appreciate the presentation and also other people sharing. But we'd really like to ask you to complete the survey. So it's in the chat and you can just click on it. It's from Colleen. Lots of other comments coming in after, so you may have to scroll up just a little bit to get that. Maybe Colleen, type it in again, please. And thank you all very much.
Thank you.
Thank you, everyone.